Assalamualaikum and a very good day. My name is Elliesya Effandy and my student ID is 012-023-071546, and today I'll be presenting a fascinating clinical case titled Ischemic Cardiomyopathy Secondary to Asymptomatic Coronary Artery Disease, adapted from a report published in Curious. Alright, these are the contents that we're going to cover today, including the definition, patient background, initial clinical findings and labs, advanced imaging findings, diagnostic interpretation, multi-system involvement, treatment approach, outcome and recovery, clinical implications, and also, lastly, the conclusion. Before we dive into the patient, let's briefly define the core condition. Ischemic cardiomyopathy is a type of heart failure that results from a long-term reduced blood flow to the heart muscles. This reduced perfusion, usually caused by coronary artery disease, leads to repeated injury, scarring, and weakening of the heart walls. Over time, the heart's ability to pump blood efficiently declines, leading to symptoms of heart failure. Importantly, the myocardial damage can occur silently, without any chest pain or warning signs, making early detection a real challenge. Our patient is a 46-year-old male with a history of hypertension managed with ramipril and amlodipine. He was a non-smoker, consumed around 12 units of alcohol per week, and had no known family or personal history of cardiac disease. He presented with a 5-week history of progressive exertional dyspnea, swelling of both legs extending to the scrotum and penis, and paroxysmal nocturnal dyspnea. He reported reduced oral intakes and occasional palpitation. Notably, he denied any chest pains, cough, fever, or hemoptysis, making this case more diagnostically challenging. The initial clinical findings and labs include heart rate was 103 beats per minute, respiratory rate was 18 cycles per minute, and his oxygen saturation was 96% on room air. Upon lung auscultation, he had elevated jugular venous pressure at 5 cm and bibasal crackles were noted. Upon abdominal examination, it was found that there was some abdominal distension with hepatomegaly and also ascites. His laboratory findings shows that his hypoatremia was at 129 millimole per liter, acute kidney injury with marked exothermia with uremia at 19.8 millimole per liter. His creatinine levels was at 198 micromole per liter, and his ALT was marked elevated at 2022 IU per liter, increased bilirubin at 38 micromole per liter. His troponin levels was at 159 nanogram per liter, and his BNP levels exceeding 1500 nanogram per liter. Now let's move on to the chest X-ray. His chest X-ray shows a cardiothoracic ratio of 0.56, suggesting cardiomegaly, along with moderate right-sided pleural effusion. Now to the advanced imaging findings. Computed tomography pulmonary angiography (CTPA) was performed, and it ruled out pulmonary embolism, but showed a significantly enlarged heart with contrast in reflux into the inferior vena cava and hepatic veins, alongside a right-sided pleural effusion. Echocardiography revealed several key abnormalities, including severely dilated left ventricle, left ventricular ejection fraction of just 16%, apical thrombus, biatrial enlargement, and lastly moderate tricuspid regurg. Cardiac MRI later confirmed transmural post-ischemic scars in the inferoseptal and apical regions. These findings suggested repeated, unrecognized myocardial infarction, despite no reported chest pain. So, what was the diagnosis? The diagnosis here was that the patient had type 1 silent myocardial ischemia, This refers to ischemia occurring in a patient with asymptomatic coronary artery disease with no prior anginal symptoms. These silent episodes had led to irreversible myocardial damage and ultimately to ischemic cardiomyopathy. Interestingly, this case also involved the liver and kidneys. The liver was congested due to elevated venous pressure, likely congestive hepatopathy, and the kidneys suffered an acute injury, most likely due to hypoperfusion and venous congestion. This cardiohepatorenal illustrates how heart failure can trigger multi-organ dysfunction. Fortunately, both liver and kidney function improved with proper diuretic therapy. The treatment approach here is medical therapy focused on guideline-directed heart failure medications, including bumetanide for diuresis, bisoprolol, a beta blocker, dapagliflozin, an SGLT2 inhibitor, sacubitril, valsartan, ARNI, ivapradine to reduce heart rate, spironolactone for neurohormonal blockade. After just 3 months of consistent therapy, the patient's ejection fraction improved dramatically from 16% to 41%. The graph right next to this shows the improvement from 16% to 41%. He was also scheduled for diagnostic coronary angiography to evaluate any revascularization potential. This outcome shows how medical therapy alone can significantly reverse systolic dysfunction, even without surgery. This case highlights several clinical implications, with the first one being silent myocardial ischemia is real and often underdiagnosed. Absence of chest pain does not mean absence of disease. Cardiac imaging is essential in unexplained heart failure. And lastly, guideline-based therapy can significantly improve outcomes. This case also reminds us to stay vigilant in assessing younger patients who don't fit the classic profile of coronary artery disease. In conclusion, this case illustrates how silent coronary artery disease can silently progress to ischemic cardiomyopathy and heart failure. With the use of echocardiography, MRI, and comprehensive medical therapy, these patients saw meaningful improvement and a much better prognosis. That is all from me today. Thank you for listening.